So we have only one regimen for new cases or treated cases, but he should be a drug sensitive. Because in 16, it was possible to know day one that with the gene expert that whether person is sensitive or before that, it was not possible to know. Molecular diagnostics were not there. So that's why it was started like this. And they say that this only one regimen for all new cases of tuberculosis and even treated cases of tuberculosis, but they must be a drug sensitive. They must not be a rifampicin resistant. That was that was change has been made. And you know the history that when RNTCP was there and it was changed to National TB Elimination Program, not that we are going to eliminate TB by 2025, we are going to end TB by 2025, but we are moving towards TB elimination. And then time came of 2017 guideline. This was for drug-sensitive TB. This was again WHO guideline. It came and that had changed most of the management of drug-sensitive TB. And in that, drug-susceptible TB, I'm sharing. This was the regimen, only one regimen. You can read either new patients or previously treated, but they must be sensitive. Now possible to know by the gene expert. So again, 4 drug for 2 months, 4 drug. There is no extension of the intensive phase. Here it was removed. Initially, if sputum is positive after 2 months, one can extend 1 month of intensive phase. But later on, they said no, there is no use of extending. So no extension, 2 months, 4 months of 3 drug. Total duration is 6 months. That was the standard short course since 2017. This is being used, but we also know that there is no need to extend IP. I say intensive phase. Initially, we used to extend, and CP in both new and previously treated cases may be extended for 3 to 6 months, especially in a CNS TB, skeletal TB, disseminated TB, and in some of the conditions, even steroids were advised. And this is the 5 weight bands was introduced in 2019. And depending on the FDCs, what you are practicing today is that these weight bands. And then index TB guideline also was developed in India. This was the first guideline in world developed in India, and this was luckily I was also part of this guideline, and it was released in 2016. The module was released in 2013. So this was about the drug sensitive. As far as drug resistant TB, first guideline of programmatic management of drug resistant TB came in 2017. And in 17, we have divided these drugs into group 1, group 2, group 3, group 4, group 5. This was the division of anti-TB drugs for management of drug-resistant TB. In group 1 was first-line oral anti-TB drugs like INH, rifampicin, ethambutol, paragenamide. Group 2 was injectables like Strepto, Cana, Amica, Capromycin. Group 3 was fluoroquinolones like Cipro, Ofloxacin, Levofloxacin, Moxifloxacin. Group 4 were oral bacteriostatic second-line drugs like ethionamide, proethionamide, cycloserine, PAS. Those were the group 4 drugs. And then group 5 was anti-tuberculosis agent with unclear efficacy, not recommended by WHO for routine use in MDR-TB. That was a story in 2006. And then the clofazimine, amoxiclav, and then clarithromycin was there. Now it has been removed from the list. Linezolid came at that time. So these were the scenario. Then we have defined the drug resistance at that time as a monoresistance, resistance to one first-line anti-TB drug. Most common was isoniazid. Since isoniazid was a drug which was used in India for a long time, so most common drug resistance was isoniazid resistance. And then poly resistance, poly means more than one drug, but other than MDR-TB. Poly means resistance to INH and streptomycin, because these two drugs were used in India. That was a poly drug resistance. And then we have multi-drug resistance. You know that isoniazid rifampicin resistance. You have extensively drug resistance, resistance to any fluoroquinolone, or at least one of the three second-line injectables. So extensive drug resistance previously was defined differently. It was apart from MDR-TB, fluoroquinolone resistance, and plus one of the three second-line injectables like Caprio, Cana, and Amikacin, in addition to MDR-TB. And then we have rifampicin, with the advent of the gene expert machine, you know that now it is possible to know rifampicin resistance. So this term was used as rifampicin resistance, but it was taken as surrogate marker for MDR-TB. Why surrogate marker? Because there's a many studies done in this country that in wherever there's a rifampicin monoresistance, 95% of the patient, they have isoniazid resistance. So, and there was extreme drug resistance, what we call is nowadays total drug resistance. And that was the regimen for MDR-TB. You know, 6 to 9 months of kanamycin, levofloxacin, ethionamide, cycloserine, pyrazinamide, ethambutol. 2, 4, 6 drug in intensive phase for 6 to 9 months, and 18 months of continuation, levo, ethionamide, cycloserine, and ethambutol. So that was the regimen for MDR-TB. And there were many more regimens were devised depending upon which type of pre-XDR-TB we had different. We have with new drugs, without new drugs. I will leave this slide to you if you are interested. And the first PMDT guideline was, treatment. Initially, no isoniazid resistance was, there was no regimen for isoniazid drug resistance, monoresistance. But now, lately in isoniazid monodrug resistance was introduced. You know, today it is being used 6 months of REZ plus levofloxacin. So, till 2022, many patients, and WHO consolidated guideline of drug-resistant tuberculosis came 1920, and based on this, PMDT guideline 21 was made. And in PMDA guideline 21 was made, that newer drugs were introduced in the meantime, pretorminate, bedaquiline, and delaminate. These are 3 new drugs were introduced in 2014. And now the classification, this is a classification, very known classification, Group A, Group B, and Group C. Group A means now, this is the latest classification we have, levofloxacin, moxi, bedaquiline, linezolid. Levofloxacin is not a repurposed drug. Moxifloxacin is a repurposed drug. Bedaquiline is a repurposed drug, a new drug, and linezolid is a repurposed drug. Then clofazimine and new purpose, clofazimine, cycloserine, and then other drugs what we used to like ethambutol, delaminate, pyrazinamide, imipenem. And then group C was decreased. So, one thing you have to understand, these classification based on their efficacy and based on that. So group 1 is the most efficacious, and followed by group B and group C. That is why we made, even, the definition of pre-XDR-TB and XDR-TB was changed with this new drug classification. Pre-XDR-TB was bacterial strain that are with resistance to fluoroquinolone, that remained same. And then XDR-TB, since injectable we have removed, so any fluoroquinolone, plus at least one additional group A drug like bedaquiline and linezolid. So that was the change happened recently. And now we have got standard DR-TB regimen, one for monoresistance, another for shorter MDR-TB. MDR-TB has shorter shorter, and then we have a longer oral regimen. And you know that I'll not go any details, but you now find this is all mono or poly drug resistance. This is the shorter drug regimen you are using nowadays. And then we have all oral longer regimen you are using nowadays. I need not to explain. And then we have newer like BPAL regimen. So these regimens are used nowadays. So I will be stopping here, and I think next time when there will be third part of it, and we will be talking something about future of the TB treatment. But you know that these are the drug-resistant TB regimen which is currently being practiced in India. Every drug is free of cost, and this is used everywhere. It is available.